Good evening, everyone. Good evening. Okay, I think let's try that again, right? Good evening, everyone. Good evening. Okay, that's more like it. Welcome. I'm Dr. Eileen de Villa, Toronto's Medical Officer of Health, and welcome to all of you to Diverse Dialogues, Stigma and Breaking Barriers, the latest edition of the Charles Hastings Lecture Series, hosted by the team at Toronto Public Health. I wish I could say it's lovely to see you. I actually can't see you from here, but I can hear you. So it's lovely to hear you and to know that you're out there, gathered here together at this beautiful Isabel Bader Theatre at Victoria University, here at the University of Toronto. As much as I look forward to seeing you and not just hearing you, I am still in awe, and I still marvel, and I'm very grateful for the ability to gather in person. Before we proceed any further into our evening, I wish to first acknowledge the land on which we gather, and recognize that our current landscape is a product of the sacrifices of Indigenous ancestors. For thousands of years, the land on which Toronto Public Health operates has been the traditional land of the Wendat peoples, the Haudenosaunee, the Anishinaabe, the Chippewa, and the Mississaugas of the Credit River. We would also like to acknowledge that the city operates on Treaty 13 territory signed with the Mississaugas of the Credit. Today, this meeting place is still home to a vibrant urban Indigenous community representing the First Peoples from across Turtle Island. And we are grateful, truly grateful, to have the opportunity to work and live on this land. As we reflect on the reason we gather today and consider how stigma and bias affect our health and our health choices, we must recognize how these very factors have affected and continue to affect Indigenous peoples. Social determinants of health, or rather the social factors that impact on health, like income, education, access to culturally safe healthcare services, these disproportionately contribute to negative health outcomes for Indigenous people. As a public health organization, we must meaningfully consider our role and how we have historically been complicit in ongoing violence that is tied very closely to these very same biases and stigmas. In doing so, we can begin to work towards action-driven reconciliation that contributes to the health and wellness of the Indigenous communities. I also wish to acknowledge that we are all treaty peoples, including those who came here as settlers, as migrants either in this generation or in generations past, and those of us who came here involuntarily, particularly those brought to these lands because of the transatlantic slave trade and slavery. We pay tribute to those ancestors of African origin and descent. So I'll thank you for your attention to that. So, colleagues and friends, this evening we have gathered to examine the broad and pervasive topic of stigma. As Toronto Public Health, we are the largest local public health in Canada, and I can actually tell you on good authority that this very topic is something that is apparent on a regular basis in our practice and our work. It is something that we deal with every single day. As many of you have likely seen over the last few days, and I would dare say over the last few hours, there is quite the discussion that has emerged since British Columbia has proposed a modification to their federal exemption for the simple possession of small amounts of drugs for personal use. The little buzzy device in my pocket keeps reminding me of the things that are happening on a pretty regular basis, and I'm sure each of you has one of these devices as well. Anyway, with respect to British Columbia, As I understand it, the aim of their proposed modification is to equip law enforcement with additional measures to address public drug use. And it's in the aftermath of that announcement that we've actually seen criticism of Toronto's decriminalization efforts. I'm also here to tell you that what I've also heard ranged from veiled criticism to frankly outright bold moral judgment of people who use drugs and who suffer from substance use disorders. Toronto, like many other areas, is grappling with the intertwined challenges of untreated addiction, pervasive mental illnesses, and homelessness. This is a triple crisis that demands solutions from the whole of society and all three levels of government. Simply put, we have never seen this toxic a drug supply, this level of homelessness, and along with it, this level of mental health crises and challenges in our history. To say nothing of the lack of available harm reduction and treatment options, one of the major roadblocks in the path of addressing this crisis is the stigma that people who are most in pain face. Folks who are not only suffering from addiction and mental health, but who have no home. If only they could get their acts together. If only they made better life choices. And I'm sure you can come up with many other statements of your own example that you've heard, whether it's been in the last few days, the last few months, the last few years. This stigma creates a web of shame, fear of judgment and isolation, and the fear of criminalization makes it far less likely that someone will seek help. And when they do finally work up the courage to seek out that help, the discriminatory attitudes that they can face within our healthcare system does not support the path to recovery. What can I say but that addiction is a complex disease. It is not a moral failing. And this is just one of the ways in which stigma impacts our population. Tonight, we all have the benefit of hearing from engaging thinkers, from leaders and change makers. So let's get down to it, and let me introduce you to the remarkable people that we have soon to join me here on stage this evening. We have Dr. James Makokis, Two-Spirit Cree physician from Saddle Lake Cree Nation, 2S LGBTQ+, Indigenous diversity and inclusion expert, and super interestingly, Season 7 winner of the Amazing Race Canada. And I think you're going to hear from James that the last time he was here, it had something to do with the Amazing Race. So I'm counting on you. He told me it was a wonderful time that he had the last time he was here. So I need you to make sure that he gets the same kind of reception as he did at the Amazing Race. Okay? Just a small challenge to put out to all of you. Of course, we also have Dr. Notisha Massaquoi, assistant professor in the Department of Health and Society at the University of Toronto, Scarborough, and founding director of the Black Health Equity Lab. And I think you're going to really benefit from hearing her very wise words. And last, but certainly not least, Michel Rodrigue, President and CEO of the Mental Health Commission of Canada. I hope, like me, that you are also looking forward to hearing their perspectives, to hearing about their insights and their work, and their diverse experiences on the topic of stigma and the power of breaking down barriers to create a healthy community. So with that, I'm going to ask you to join me in welcoming our first speaker to the stage, Dr. Notisha Massaquoi.
Wake up, sound the alarm. Ring the alarm, ring the alarm. Ring the alarm, ring the alarm.
Now, either I'm going to teach you a very elaborate TikTok dance now, or we're going to have a very intentional conversation about stigma. You choose. No, I'm just joking. I'm really, really honored to be here and excited They told me it was TED Talk style and I should walk around, but I'm used to lecturing, so maybe I'll just keep one hand here on the podium and move a little bit. The theme of my talk today, if you didn't get it from my entrance music, is ringing the alarm. And it comes from the mission statement of my research lab at the University of Toronto, Scarborough, and the Black Health Equity Lab, ringing the alarm of Black health disparities, working with Black communities for change. We understand in this lab that Black health disparities, based on how we exist in this society as Black people, oftentimes there is no alarm that is rung when we have negative health outcomes. And oftentimes stigma shows up instead of the care and support that we require as Black people in Canadian society. I love to show you this picture of the students in the lab. This is who inspires me to do this work. This is the future of healthcare. These are the next set of health policy makers. These are the next healthcare providers. These are the next health researchers. Stigma does not exist without marginalization and discrimination. In fact, stigma is a core and essential tool within anti-Black racism. What's the purpose of stigma? It's something we have to ask ourselves, particularly as those of us working in the healthcare system. It creates shame, it creates fear, hopelessness, and isolation for communities that become stigmatized in a very oppressive system. And from a health perspective, what's important for us to understand is that it undermines every aspect of the healthcare cascade. It undermines diagnosis, it undermines treatment, it undermines equitable access to care, and it undermines successful outcomes. Addressing stigma then becomes very fundamental for those of us that are working in the healthcare system. It's very fundamental, and it is required that we eliminate stigma so that we can actually guarantee the well-being and survival of Black people. So, if I was to ask everyone in this audience, what did you learn in school about the contributions that Black people have made in Canadian society? I think the Jeopardy music is playing now. Most of you are going to tell me nothing. Most of you are going to tell me very little. And just to give you some runway, enslaved African people arrived in Canada in 1604, so you have almost 500 years to work with. But most people cannot name a Black person and talk about their contributions to Canada. We learn to stigmatize the Black community from very young in our school system. People who are not contributors are not seen as valuable. And we learn from very young in our school system that Black people and their community are not valued people. They're not contributors. So the stigma begins from a very young age. It's also important to understand what you're learning is that the absence of Black people, right? When we're absent from spaces, we're not on your street, we're not in leadership in your organizations, there's no alarm going off. Wait a minute, valuable people are missing. So it's very important to understand where and when stigmatizing Black people starts in our system. I was reminiscing with Dr. de Villa before we started. A lot of people don't know that maybe almost 30 years ago, I worked in public health. The Scarborough office, it was before amalgamation, and I was an HIV surveillance officer. But prior to that, I started working in a small organization when I finished grad school in Toronto. And our goal was to provide services to continental African people who were newly diagnosed with HIV, but it was before we had medication. What I learned from that experience, other than sitting in my office every day praying that nobody would walk through the door for service, because everyone who did walk through that door for service would pass away within a year. We had no medication. But when we did get medication, when AZT first arrived in Canada, what I saw was the effects of stigma. African people were blamed for bringing HIV to Canada. African people were stigmatized in terms of having unusual practices, unusual sexual practices, all kinds of stigmatizing labels were given to this community. And therefore it led to people losing their jobs if discovered to be HIV positive, service providers refusing to provide services, doctors dropping them from their roster. This community was the last community to access medication. Now, what happens when that level of stigma goes unaddressed, unchallenged? Let's speed ahead to 2016. I'm the executive director of Women's Health and Women's Hands Community Health Center. It is the only community health center in North America that specializes in primary health care for Black and racialized women. Two things were noted in 2016. 90% of all babies born HIV positive in the city of Toronto were born to Black birthing parents. No alarm went off. And within our health center, the numbers of Black women testing HIV positive, showing up HIV positive, was increasing exponentially. No alarm was going off. There was no research being conducted. I couldn't find any answers to explain why we were seeing what we were seeing in our health center. Was it a one-off situation, unique to our health services, our health center? Was it because we were in downtown Toronto? Or was there something else going on? I approached the Public Health Ontario lab and asked for assistance to please provide us with race-based data, to please show us why this was happening to Black women in particular. And they pulled the data. But what they saw was a positive downward trend. So all was well. No alarm was going off. Things were going as planned. HIV prevention strategies were working, and we were seeing the reduction of HIV in the province of Ontario. I asked them to pull the data based on gender because I'm working with women. Again, no alarm is going off. Most cases at the time period I was looking at were found with men. Very few women in relationship to men were contracting HIV. In fact, our services are very designed around a male client when it comes to HIV. There is no HIV specialty program in our province for women, even today. Not answering my question. I asked them to pull the data for African, Caribbean, and Black communities, and we start to see what I was seeing. Things look different for this community. It's almost a 50-50 ratio when it comes to male-female HIV acquisition. Still not answering my question. I asked them to look at women only, and then let's look at race. And here's the answer. Stigma that goes unaddressed creates enormous disparities, particularly for Black communities when we're talking about anti-Black racism. In every health region of our province, Black women had the highest rates of new HIV infections with no alarm going off. My clinic was located in Toronto Central. Black women made up 70% of all new HIV infections, and we only make up 9% of the city. It didn't matter where we lived in the province as Black women. You could see the rates of new HIV infections for this population with no alarm going off whatsoever. Stigma unaddressed does not allow us to look at the systemic barriers in a system. It does not allow us to actually help those valuable people, help those people that are contributing enormously to Canadian society because we've learned from very young that they do not matter. They are not important. One of the things that we have to understand, particularly when we look at pandemics and epidemics such as HIV, is that a pandemic will show you all of the cracks in your society. And then it goes into those cracks and blows them up to allow the most marginalized members of our society to fall in those big chasms that get created. One of the things that became very evident to me in my work was that we have a pattern. We have a pattern during pandemics of how we treat particularly Black and Indigenous communities. And stigma is very core and central to that pattern. So during the COVID pandemic, what you have to realize that at that time, the Black community was at the highest rates of HIV acquisition. So we were already in a pandemic, the HIV pandemic. And during the COVID pandemic, so our second pandemic that we're navigating at the same time, Toronto Public Health declares anti-Black racism as a public health crisis. So the pandemic of anti-Black racism is also being navigated by the Black community, particularly with the murder of George Floyd. So the first component of the pattern that I want to talk about is that when pandemics are coming, Black community members are often the first to stand up and say, please collect race-based data. Please collect race-based data. It is essential for us to understand what we're about to experience. And race-based data will help us understand the magnitude of what we're about to experience. And so Toronto Public Health was approached, lots of lobbying, and they complied. They worked in partnership with the community to produce race-based data for COVID acquisition. The first data comes out and we see what we already knew we were going to experience because we've had the experience with HIV, that the Black community had the highest rates of COVID. We make up 9% of the city of Toronto. Our COVID rates were at 21% at this point in time. They escalated. We had the highest hospitalization rates and the highest death rates for the city. In fact, COVID was heavily racialized in the city of Toronto, with 83% of COVID cases being folks from racialized communities, but the Black community having the highest rates. Sometimes we identify the disparity, which is very important, but we don't often respond. We don't often react. We don't ring the alarm. Vaccine hesitancy is high among Black residents, and that means we have to do everything possible to provide them with the information they need to get around and get over that hesitancy. The stigma of vaccine hesitancy, that Black people are hesitant. We're afraid to get vaccinations. That became the rallying cry. The stigma was introduced. The stigmatization of the Black community during COVID was introduced. If I was to map the COVID rates for the city of Toronto, this is what it looks like. The darker the red, the higher the COVID rates. If I was to map HIV against that map, it almost lines up exactly the same, with HIV actually spreading out wider as Black communities start to move out of the city into the suburbs. But Toronto has a current caseload of making up 39%. The Black community makes up 39% of the HIV cases. And then we could see central east of Toronto, central west. The rates are still extremely high when we only make up 9% of the city. Now, if I was to take a map of the Black communities in Toronto, the darker the brown, the higher the population of Black people in those neighborhoods. It sits right on top of the map of COVID and the map of HIV. Very interesting. Stigma shows up again, because if you think about the neighborhoods in the city that have the highest populations of Black people, we already stigmatize those neighborhoods. They get stigmatized as dangerous neighborhoods, problematic neighborhoods. So even the spaces that Black people are living in involve stigma. Now, if I was to take this map of density, the darker the brown, the denser the population, the higher the rates of COVID, the higher the rates of HIV, and the more Black people live in these spaces. And we were telling people to socially distance themselves, to isolate themselves. But they're living in some of the densest neighborhoods in our city, with no other solution being offered. Now, if I was to take the transit map and place it on top of the map of where Black people live and where COVID is prevalent, we could see that these white dots are the ends of the subway line. This is where the subway line stops. The subway in Toronto stops before every neighborhood with the highest percentage of Black people with the highest rates of COVID. All of our services for HIV, for example, are located in the downtown core. So to travel, even to get to the services, becomes problematic for a community that's stigmatized. And remember, the end result of stigma is isolation. The same thing with COVID. And when we think about who has to travel where, who has to leave home, who didn't get to work from home, how many buses I need to take before I get to the subway to get to the work that I have to get to. You can already see that vaccine hesitancy shows up nowhere. The stigma distracts us from the systemic barriers in our system that are creating the problem. Black people are not afraid of vaccinations. They have a healthy fear and distrust of a healthcare system that has often failed them and sometimes has harmed them. And then the policies that we put in place that did not involve consultation with the community that had the highest rates of COVID shows up like this. We get a vaccination. We're going to roll out that vaccination. We decide to roll out that vaccination first in corporate pharmacies. The communities that have the highest rates of COVID, the highest rates and prevalence of Black people, this is the pharmacy level, all pharmacies in the city, the pharmacies with COVID vaccinations. You could see how difficult it was going to be for the community with the highest rates of COVID to access the vaccination. And our final policy, we start rolling out the COVID vaccination based on age. We start at age 65 and above. I'm not going to tell you how long I waited to get the vaccination because I don't want you to figure out how old I am. We start over the age of 65. The community with the highest rates of COVID, only 7.6% of them are over the age of 65. 60% of the Black population is under 30. And then our system relies on the thing that it always does with the isolated community. Ask the isolated community to take care of themselves. And so we had to design our own COVID response with the limited resources that we have as a community that has been marginalized and isolated within the healthcare system. And then we had to develop our own screening sites, our own testing sites, our own educational programs, so that we could help ourselves, that the community that does not contribute is not seen as valuable, where no alarms were ringing to say that we need to intervene. They take care of themselves. One of the things that I'm going to end with and advocate for is the creation of stigma-free services. Stigma-free services, services where Black people can access care without the stigma of anti-Black racism, right? Where the alarms are going off all the time for this community. The students that I showed you in my lab have created such a space. They have taken a look at what does stigma do to our community and how can we reverse it? And if we look at HIV, what they've created through a pilot program is the first HIV intensive care program that is designed specifically for the Black community and located in a Black community that does not have access to any HIV services, so that they no longer have to travel all the way downtown. And that those services would be designed with Black community members. You can see our advisory committee at the top. And the services would be delivered by Black people from the community, healthcare providers. And this is the clinical care team at the bottom. And that stigma-free services has to be part and parcel of creating access to healthcare and guaranteeing the well-being and survival of all Black people in our system. I want to thank you. And we have a wonderful, wonderful lineup. I'm just the opening act today. And I look forward to the questions that are going to be coming about stigma-free services.
Please welcome to the stage Michel Rodrigue, President and CEO of the Mental Health Commission of Canada.
Thank you for that warm welcome. I'm really honored to be here and to share the stage with Doctors Massaquoi, Makokis, and de Villa. It's truly an honor. And I'm really proud to see in the room, at least what I can see, colleagues from the sectors whose work is transformational and has been truly inspiring. There's a popular tune used in grade school to teach children about the body. Now, I come from a French home, so I was late in learning this particular song. You might know it, but if you don't, and really against my much better judgment, I'm going to try to sing it to you. So it goes like this. The leg bone's connected to the knee bone.
Them bones, them bones, them dancing bones, them bones, them bones, them dancing bones, them bones, them bones, them dancing bones, doing the skeleton dance. The foot bone's connected to the leg bone's connected to the knee bone's connected to the thigh bone, doing the skeleton dance. The thigh bone's connected to the hip bone's connected to the backbone's connected to the neck bone, doing the skeleton dance.
All right, now, where is the head bone connecting? And I think in many ways, we have to consider our public health system like singing the skeleton song. We feel like we need to remind policymakers in a very simple way that the head, our mind, is actually connected to the body and is integral to our well-being. I may be waxing to the obvious in this room, but this message really needs to ring clear and true. After all, 1 in 3 Canadians, that's about 9.1 million Canadians, will be affected by a mental illness during their lifetime. So support for preventative public health measures is certainly key. In other words, we cannot decouple fiscal planning from social outcomes if we want to respond to the need of our times. And what are the needs of our time? Well, as a society, we've been in crisis now for close to 4 years. First, the pandemic, then awful conflicts throughout the world, displacements of millions of individuals, cost of living pressures, floods, wildfires, and other impacts of a changing climate. In this extreme volatility, it creates a state of uncertainty and crisis. And really, what you're feeling is that there's an unceasing stress. And people can't differentiate what I need to be alert to as a danger because there are so many influx of crisis and bad news. those factors actually also differ greatly depending on your age, geographic area, place of birth, gender, and social economic status, among other things. And our fracturing mental health became a common theme. That was true throughout the pandemic and also remains true today. And in some instances, this more open dialogue on mental health has been a silver lining of sorts. More open conversations certainly help reduce stigma. According to Statistics Canada data, that's from 2022, more than 5 million Canadians aged 15 and older met the diagnostic criteria for mood and anxiety or a substance use disorders in the previous 12 months. Further, 1 in 3 of those reported unmet or partially met health and mental health needs. And we know that this need keeps growing. And those who provide care are burning out. Some have to fight internal battles within their own organizations. Others have to try to work within a system that perpetuates stigma. Now let's pause a little bit. Current research frames stigma as the presence of socially undesirable characteristic which signals otherness. In our work at the Mental Health Commission of Canada, we've examined 4 types of stigma. Individual, the kind that you internalize from negative messages. Interpersonal stigma, which can arise within relationships, in your friends, your family, or with colleagues. Structural stigma. It encompasses organizational rules, policies, procedures, laws, and cultural norms that perpetuate or increase stigma. And lastly, intersectional stigma. That happens when stigma related to mental health or substance use overlap with other forms of inequities. Dr. Massaquoi and Makokis both shared really clear examples of that. Now for us, structural stigma has been an area where we have found we need to do much more work. It comes with authority. If a policy is put in place from the very top, then others lower on the org chart may not even question it. A good example, in research done by the Mental Health Commission of Canada, we worked with an organization that previously and frequently brought out a restraining chair for clients who had a mental health issue. That was based on a stigmatizing assumption. Mental health clients needed and were likely to be aggressive and violent. Through focus groups and reviews, through supports from people with lived and living expertise, and through the work of behavior analysts and recreational therapists who are actually better able to engage with patients without relying on restraints. The team has not only had to use its safety restraint chair in more than 4 years, so they haven't used it in more than 4 years, while prior to this, it was previously a near daily occurrence. The Mental Health Commission of Canada is working with healthcare practitioners on implementing a structural stigma toolkit to support and work with providers to help reduce stigma within our healthcare practice. So we know what healthcare practitioners have a role to play. We know governments play a pivotal role. But what is the role of public health in mental health? Well, from our perspective, healthcare in Canada is often much too reactive. We often treat people only when they're sick. If we got back to the core values of prevention and promotion, we could better manage our own mental health. Earlier intervention could better channel our very limited resources. At the Commission, we've been working for years on mental health literacy. We've trained over 1 million people in Canada at this point. Our goal is really to work upstream, to give people the tools to help themselves through education, courses, and other literacy tools. This allows them, it empowers them to take their mental health seriously and make it a priority in their communities, in their schools, and workplaces. It's a societal impact we want to have. It is the key to our work. It's why we all get up in the morning. Here in Toronto, we have seen an inspiring project that could serve as a model for other cities. I learned of Thrive Toronto in conversations with leaders. Its goal is to transform Toronto into a city where everyone can thrive through a mental health plan. It brings together municipal, provincial, community, and national organizations, including the Canadian Mental Health Association in Toronto and CAMH, to work towards a common goal and to face intersecting challenges. Supporting housing and workplace mental health are key pillars. This puts preventative health measures on the public agenda. Now, let's talk about preventative mental health measures and how they fit on the public health agenda. Through a social determinant of health approach and a focus on prevention, we can reduce the burden on acute care settings. It includes a wide range of services from individual counseling, case management, detox services, housing, crisis, and employment services. It also includes mental health promotion and preventative, proactive interventions for people who are more at risk. Mental health services delivered at the community level should be and can be integrated with social services and primary health care. Of course, none of this is actually possible without funding. And we know that funding in mental health is crucially important. I'm an accountant by trade. I also know there's a key return on investment. Numerous studies the world over have shown a near doubling for every investment in proactive mental health. It reduces burdens elsewhere in the health system in terms of hospital beds, healthcare labor, and other supports. Without investments in prevention, our society gets stuck in a self-actuating crisis cycle. There's often a case that there's one word I really stop on. So with all of this, what's our hope for the future? Well, at our end, it's that younger generations feel fewer barriers to seeking help. They don't feel the same weight of stigma. We hope that everyone has access to culturally adapted approaches to care. We really hope that we will have tackled stigma. And I'll take Notisha's wording on that. Let's hope for stigma-free services. And I really hope that e-mental health will have helped us increase access and manage the demand for care. So, if the knee bone's connected to the leg bone, and I really won't try to go there again, we know the role of the mind in our overall health. It seems almost absurd to consider mental health as not part of the whole system. Just as we have tackled infectious diseases and promoted physical health, so too must we now elevate the prevention of mental health challenges to the forefront of our agenda. Going forward, we draw upon a rich tapestry of values and history that really underpins public health in Canada. Health leaders here today, let's heed the call to invest in mental health education, community support networks, and policies that prioritize prevention. In doing so, I think we will uphold the fundamental principles of public health: equity, solidarity, and collective action. May our shared commitment to the well-being of all guide us in the days ahead. Thank you. Merci.
Please welcome back to the stage Doctors Eileen de Villa, Notisha Massaquoi, and James Makokis for a thought-provoking panel discussion about stigma and its impacts on our health and health decisions. I should have brought something to write on.
Okay, we're just going to get ourselves settled up here. And let me start off first with a note of thanks to all three of you for sharing your remarkable insights, your experiences, and your depth of knowledge on this subject. A fascinating conversation, even from the back of the stage, right? If I may say so myself. And so this is the panel component of, the panel discussion component of this evening. But before I launch into this, I just want to let the members of the audience know that while I get the first crack at asking questions and stimulating some conversation amongst these three wonderful, wonderful speakers, there will be an opportunity for you. So I know that there will be some folks, some colleagues I have out there who've got microphones in hand. So if you haven't thought of your questions yet, please start thinking of them now. You will have an opportunity to ask some questions of this remarkable set of individuals. And I know that there'll be no shortage of questions, I'm sure, from this audience, because there's so much to talk about. So let's get into the questions. Are we ready? Sure. Everyone's got water. We're all set to go. Mm-hmm. Good. Perfect. Just relax. I think this is a great opportunity to launch into some real conversation. We had some conversation before the evening started, and so let's continue. But let me pick up on some of the points that were raised. Michel and Notisha. Michel, first you talked about us being in crisis mode after the last, few years. Lots of things going on, no shortage of crisis going on in our world. And Notisha, you spoke to the need of raising alarms, right? So what I was thinking about is, how do we do that in a productive way, right? How do we raise alarms without being alarmist? How do we raise alarms given that there is so much going on in the world that people feel that they are constantly reacting? How do we do this in a productive and resonant way so that we can actually achieve the kinds of goals and outcomes that we're seeking to achieve? So I'll put that question out to all three. Perhaps, Notisha, I'll start with you, go over to Michel, and see, James, if you'd like to add to that as well.
It's a great question, and you're correct. We don't have to become alarmist in the raising of the alarm. The first thing that we need is consistent collection of race-based data. And Black community has been asking for this for decades. Once we understand who has the highest health need in a particular situation, the formula is very simple, right? The community with the highest health need should get the most resources at that particular time, should get the most attention, and should get the most dedicated care and response. And that's not at the exclusion of other people, but it's understanding that the people that are most in need at any decision point, right, have to get the most resources at that moment of time. We don't do that. We don't do that. We tend to look at the communities that are in most need, and if we look at chronic illness, if we look at any of the stress-related illnesses, hypertension, heart disease, diabetes, I mean, we can go on and on and on. We'll see Black and Indigenous communities at the bottom of receiving the support with the highest rates of those issues. So we have to actually flip our system almost upside down, because the way that it responds now is the people most in need get the least. And what are we going to do to actually change that dynamic? So when I'm saying ring the alarm, I'm really saying I'm asking us to use a more transformational way of delivering services that are actually going to guarantee the survival and well-being of Black and Indigenous people.
Yeah, that's great. Michel, thoughts on the question?
Yes, thank you. Maybe another approach. I fully agree that evidence needs to inform future, and if you don't measure, you don't count, and that's true. And so thank you for sharing that. I think just like you start your meal, sometimes I'm served with a large meal, I'm thinking, I'm never going to get through this. Well, surprise, surprise, one bite after another, you get through it. So I think we need to take small bites, and that's how you start. So if we want to change things, I think we need to start at elementary and high school level, and certainly post-secondary, and really tackle those stigmas and stigmatizing elements. If it's around mental health, it means providing them with information so they're able to understand what mental illness is, what help seeking is, what stigma is, so that they're able to support one another. Through that, you're able to address the issues of differences and embrace those rather than being scared. So I think you can replicate that in workplaces through training to creating psychologically healthy communities or workplaces to work in. So one step at a time. I think we know that in the current context where things are very polarized, we also need to keep growing our tent. So reach out to folks who might not be perceived as allies and bring them on site so that they become allies. I'll stop there.
So it's interesting, Michel, you raised this notion of the polarized world, which was one of the comments. I actually have it written down right here in my notes, that this is in fact, something that we're experiencing. So James, I'm going to put that over to you, because I believe in your talk, you talked about the steps of dehumanizing. So in a polarized world, how do we flip that, if I can borrow Notisha's words, to what are the steps towards humanizing, and how do we effectively achieve that, particularly at this moment when there is so much polarization? Thoughts on how we might actually move forward with humanizing as opposed to dehumanizing?
Well, you have me all set up to answer the last question. So I was thinking in my head, like, oh, okay, I have a good answer.
Well, you can answer that one too. I'm not going to restrict you from answering that question, by all means, in whichever order you prefer.
Okay, I'll answer the last question, then I'll get to this one. So in terms of alarms and being alarmist, I think that's something that, if we think about Indigenous communities, Indigenous health, there's always an alarm. There's an alarm of like opioid crisis and epidemics or suicides or like any number of things that really spells out the complete destruction of our societies by Canadian law. And so when we look at societies around the world that, are developing nations or things like that, it's always from the systematic destruction of the original societies. And it's important to situate that because it removes the blame from, the group or individual to who caused that to happen. And we were just in South Africa, and like all we heard was about Dutch history. Like, what about the original South African history, which was nowhere in any of the tours. And so when we normalize erasure, then it's easy for us to think that a group is completely, deficient and meant to be violent and all of these things. And I'll just give the example of the Blackfoot people in southern Alberta in Treaty 7. So in the early 1900s, Abraham Maslow went to go study the Blackfoot people's Opikanawasswin, the way that they raised children. And from his research, he developed the Maslow's hierarchy of needs, which didn't give any credit to the Blackfoot people. But in that, one of his findings was something to the effect of like 95% of Blackfoot people achieve a level of emotional intelligence that only 5% of the American population will achieve. And so knowing that system, which is the way that they raise children, which is how many Indigenous societies raise from that child-centric perspective, obviously something worked. And it worked to the extent that that was, cited in his research. And flash forward like 90 years, and that same community is now having an opioid crisis, an epidemic, where they're announcing states of emergencies. And so it's easy for us to pinpoint those Indians who have addictions and problems and lock them in the reserve, which we constantly hear in media, without looking from a strengths perspective of what was removed by the government and how do we rebuild that, which is really rebuilding Indigenous health systems. And so even in things like using cultural genocide as a term, which doesn't exist in law, it minimizes the importance of culture and spirituality as just our way of life, I guess, or things that we did to connect. But in our ceremonies, which are institutions of governance, education, legal systems, judicial systems, all of those things, like the healthcare system, like the justice system, all of those need to be rebuilt. And we never get the funding by the federal government as a fiduciary duty to rebuild those things, which keeps us in a state of constant crisis. And so it's a methodical thing by the government to keep us in a state of dependency because of our inherent connection to the lands which we never gave up. And I think those are really important points for people to take home when we're reading land acknowledgements and treaties, is that we never gave those things up. And that's why I noted the importance of women as us being matriarchal people, and they weren't involved in that process because it wasn't about giving up our lands. And so when we think about, if you Google Indigenous women, here's another good example of stigma, all that comes up is MMIWG. You never get pictures of strong, powerful Indigenous women that I know, that I'm a part and privileged to know. And again, we need to flip that, which involves your second question, which is educating your own families. Like, white people need to educate yourselves. And when we think about like ethnic minority stress and pressure, and I'm sure you feel this too, we can't always be the ones that are doing that, because we have enough work to do in our own communities to recover from this genocide. And those basic understandings, like I just get tired of hearing, I didn't know this didn't happen. Like, how many national commissions have there been that have articulated and laid this out since the Royal College, Royal Commission on Aboriginal Peoples in the 1990s? So that's the important part of allyship and solidarity, is that piece of educating yourselves about how we're supposed to be here so that we can actually start doing transformational research in Indigenous health or trans health that moves just beyond descriptive qualitative research that pathologizes us. And that's the work that I'm trying to do now. And I'll just give an example and then shut up because I don't want to take up this whole, one of the things that we just received a grant for through neuroscience is looking at intergenerational healing when Cree people are learning our languages in land-based settings, and looking at biological markers through EEGs and functional MRIs and stress markers to see how the brain heals itself when we inherently do the things that keep us healthy. And there's zero data on that. Yeah. And so, from a public health perspective, from a science perspective, do we have to validate this as Indigenous people? I think, no. But in terms of getting the funding that we need to ensure that Indigenous languages don't go extinct, because they are at risk of doing that, there is validity in that, and why we need allies to do that work.
Well, thank you. I don't think you spoke too much. In fact, I see you can't see them, but our two colleagues to your left are, clearly, focused on what you're saying. So I think it's interesting. Each of you has spoken in one way or another about education and the value of education, whether it's through the way in which children or the next generation is reared, whether it's with respect to training. Michel, you talked a little bit about, I think, secondary and post-secondary education. Notisha, you spoke about your own students and the value of education and the importance of education. So I'm interested in exploring with each of you the notion of education and teaching ourselves, members of this community here and beyond, in a time when actually getting good information, when there is so much misinformation and outright disinformation promulgated by these devices, which all of us have, how do we actually really move forward and educate ourselves well when there is so much of this going on? Thoughts on that? Notisha or Michel, perhaps I'll turn it over to you first.
Go ahead, Notisha.
And then audience members, please get ready. It's almost your turn.
The question I asked at the beginning of my talk was, what have you learned in the education system about the contributions that Black people have made to Canadian society? And I ask that question at the beginning of every class I teach, whenever I'm giving a workshop, lecture, all of those things. And the response has always been the same. Nothing, next to nothing. So the first step of educating yourself is understanding what you don't know. It's very difficult to say that you're an ally to the Black community or that you are working towards eliminating anti-Black racism if you know nothing about us in this context called Canada, or that we now call Canada, and you know nothing about our history. It's very difficult to design programs, it's very difficult to deliver health care if you absolutely know nothing about the history of this people and what oppression looks like specifically for Black people in Canada. A lot of people still don't know that we had slavery in Canada. Yeah. A lot of people don't understand that. It's important for you to know that, because to understand the context of what we're experiencing in terms of poor health outcomes goes all the way back to 1604. It's really important that we understand the context of colonization, or what that project was. The colonization of Canada is the containment of Indigenous people, the expulsion of Indigenous people who wouldn't be contained, and the extermination of those that couldn't be expelled. When Black people arrived in Canada, they arrived with the British and French, were the first racialized population to arrive in the country. We fell into that project of colonization. The root of racism in Canada is anti-indigeneity and anti-Black racism. So to understand why our health outcomes look very similar as Black and Indigenous people, you have to go all the way back to the root of our history and our experience in this country. So it's all very connected. This stuff needs to be in our universities, it needs to be in our medical schools, it needs to be a part of all the training that we have to deliver healthcare services, to design and create health policies and engage in health research. Or else you'll see the outcomes that we had during COVID, the HIV pandemic, right? And we can go on and on and on down the list. It's the lack of education and understanding who we are and what our reality is in Canada that doesn't allow us to provide services equitably to these two populations in particular. And it's also very important for us to understand that, my core work is around addressing anti-Black racism in the healthcare system, but it can't come at the expense of Indigenous people and their communities. And we all have to understand what our commitment is to Indigenous communities and then begin the work to eliminate forms of discrimination that we personally might be experiencing. So maybe now I'm talking too much.
Oh, I love listening.
There's no such thing, not here.
But when we think about public health education, when I think about my own time period working in public health, none of this was discussed at all. So how can we effectively provide support to whole populations when we know nothing about the oppression that they're experiencing and the reasons why they have the poor health outcomes that we're supposed to be managing.
So I'm going to take a little bit of hope from that to say that we're discussing it, right? Not perfect yet, but we're discussing it. Michel, how do we continue to do this? How do we continue to make sure that we're making the kind of progress that we're seeing a little bit of tonight, but we know there's much more to go, and we know that lots of information coming at people. Education is a big enterprise, for lack of a better word. How do we put this on the radar better?
So I'll start off by stating from the start that I'm an eternal optimist. The glass is always half full. So for me, I think we have clear examples. Kwame Mackenzie here in Toronto with CAMH developed talk therapy, so cognitive behavior therapies for Caribbean population. So I think expanding that to African, Caribbean, and Black populations is key. The Mental Health Commission and CAMH did a similar project with the South Asian population and demonstrated better outcomes, better health outcomes. So how does that work? You change the intervention and you train the practitioners, and then you're trying to move that forward. And I think that is what we need to do constantly. We need to change. We heard from James that there's very little training on intergenerational trauma in terms of different types of experience within your own training. So you need to inform individuals who are providing care by providing them with the right additional training that is culturally adapted, that includes community often, and also ensuring that they have the tools to provide that care in the right way.
James, any thoughts?
Yeah, I mean, this is a huge question. I think, and I just want to go back to our trip to Africa that we spent a month there. Like every single place that we went to, whether people were villagers and or living in the city, every single one of them wanted their child to have an education. And even if that meant, sending their children to school, and like their children had to carry sticks of wood that was used at the school to heat, to cook their food, or in South Africa, spending like a significant amount of their annual income for their child to be able to have an education is so important. But it has to be a balanced education. Yeah. And I think that's really important to know, which is why I brought up the Kitiasu Tamuin, Nagotoasike, Guakisemantu, Yasuin, Napakatehun, the Turo Wampum, and the Treaty Number 6 as an example. It's a good visual for how we're supposed to learn equally. I mean, I spent 25 years learning in a Western education system, and very few people can say the original names of the people whose land they're occupying, which I hear all the time in land acknowledgements. I'm like, you're not even saying that right. And so that gives an indication of the level of understanding, let alone where we need to move to. And part of that is looking at one another as humans. And that's something that we have to teach my little nephew, who I showed a picture of, because he has long, beautiful hair, and he's fully raised in Nehiauno, everything it means to be a Cree person, everything that we never had. He's given those health interventions as he's grown up. His next one will be his rites of passage when his voice changes. And we have to tell him, when you go to school, Ateo, these are some of the things that people might say to you. That they may ask you, why do you have long hair? Are you a girl? Like all of these things that we have to prepare him for, and also educating about other cultures of the world so that he doesn't go in thinking that everyone has a Muslim and kukum, like, how we say grandmother and grandfather in Cree, that there's different ways of doing that. And that's why I brought that back to the majority of the people in this country are white people. And why I said white people have to educate white people, because there's literal statistics around, 75% of white people only hang out with other white people. And so within that community, which holds the power in every institution, we need to look at the tables of like, when you're in a room of decision makers, and health is a very good example because it's very one note, that if everyone looks the same, of course we're going to continue to have the same indicators about health, and that's when we actively need to make those efforts to include people and also to create spaces for people to help transform those statistics in positive, nuanced ways.
Well, thank you, James. Notisha and Michel, I could probably go on and ask you many, many more questions, but I think I see a colleague of mine over there in the wing saying, hand it over to the audience, Eileen, stop it already. So with that, why don't we turn it over to our audience? It is, there we go, the lights are coming up a little bit so we can actually see you, and it's nice to see you. I can see Mark over there, and I see Allison at the back as well, and I see hands up. So why don't we turn it over to our audience for questions? Allison, I think you've got somebody ready to ask a question right there.
Good evening. My name is Ted Wittick, and I'd like to thank you all for this evening's presentation. This touches on pretty much your last question, Eileen, but to the group, and maybe Notisha first. What gives you the most hope in the minimization toward elimination of stigma, and would that be a springboard for what we all can do?
That's a good question. My students, and Ted, I've come to speak to your class, your students. In Scarborough, which has one of the highest rates of HIV, there are no HIV services. And with Black people, with the rates that I showed you, having to travel all the way downtown to receive HIV services, and we know all the challenges with cost and the transportation and all of those things, the students in the lab just said, well, why don't we create a service? And I've worked in this field for a long time, and we've complained about this for years. So we got together, we applied for funding, and they did receive funding for a pilot project, and have designed the Aya Circle of Care, which is the first HIV intensive clinic in a primary healthcare setting. It's located in Taibu Community Health Center. And they sat down and just asked different questions. Like, what would it look like if it was close to home? What would it look like if all the service providers were Black? What would it look like if we consulted people living with HIV at every step of the process? What should the building look like? Who should greet people when they arrive? Really detailed questions. And most of the students in the lab are undergraduate students. These are young students who are getting to be a part of a very large research study and create something that they're going to leave with the Black community to address a problem that we have. That's what gives me hope, because those of us that have worked in healthcare, I've worked in public health, we know what the problem is, but we hadn't come up with a solution. And so they did what do they call it? A workaround. Let's figure it out. That's what gives me hope, that this generation is not afraid. They don't have any preconceived ideas of what all the problems are going to be or what all the possibilities of failure are. They just get up and do it. And so I'm very excited to see, and this is their first project, and to see a clinic fully functioning with a full caseload, with the students studying what makes this successful, what is going to make this successful, and they're already planning their lobby with the ministry for core funding, so it's a permanent program that will be scaled up across the province.
That's great. It looks like Michel's not our only optimist up here at the panel.
Exactly.
So let's turn it back out again.
I won't answer that.
Oh, would you like? Okay.
Because I think it's like
James, you go
sometimes
ahead.
it's easy
That's
to talk about the negatives, but I remain. Oh, that's Fleetwood Mac Dreams coming on.
Maybe that's us trying to blow up your phone. It's
Yeah.
not quite Amazing Race style, but we're going to get there.
Well, speaking of the Amazing Race, it was so crazy to.
See, it always comes back to the Amazing Race. It always comes back to the Amazing Race.
It was so crazy to be on that show because for many reasons, but how it helped to shift the way that people think about Two-Spirit people, GLBT people, Indigenous people. And it's interesting when we talk about equity, diversity, inclusion, because in our season, the viewership went up 200,000 people because it was a diverse cast that reflected the stories in Canada. And it went up to as high as season 2, which is, I think, pretty incredible in film. But one of the things about having, us on there, my husband and I, is it humanized, and that's why I talked about dehumanization, but it humanized our experience to the point where like our key demographic who like loved us the most was like plus 45-year-old white women who like as a brown-skinned Two-Spirit guy like being chased down in a market or like to get a picture by a plus 45-year-old white woman is not the experience that we're used to. But in being on the show, we heard so many things like my 90-year-old grandmother now accepts my trans child because you gave us the chance to talk about, as a family, because it's a family show, about what it means to be Two-Spirit. Or, now my mom accepts my lesbian sister. Or, like, you change the way that we think about Indigenous people. And so that really speaks to the importance of representation and having diverse groups of people represented in the media. And if you just think of even like, and the murder of George Floyd had a huge impact on that. If we think of like Sex and the City, like the first one, completely like non-diverse cast, right? And if you think of, and just like that, there's like a non-binary person, like there's a black law professor, who's teaching Miranda about like all these things, and like, there's Asian people, South Asian people, like a completely diverse cast. And when we have a chance to watch that as, normal, they're normal people, they're not stereotypes, it can really change the way that we think. And that's when I have hope. Like, being on that show, it was incredible because of that. And, and that speaks to the importance of representation in the media. And so I have hope for people to change, because being able to change from like a 90-year-old transphobic person to like fully accepting is an incredible thing.
That's amazing. Hope and optimism, one season at a time. So, who else have we got with questions? Allison, why don't we go over to, we'll go to this side, and I think we've got, I see a hand up over here.
Thank you very much to every single one of you for educating me. So thank you for that. The question that I have, and you just touched on representation, the importance of that. And the Faculty of Medicine, they started with theme leads to change the curriculums. So a black patient walks into an office and sees a black doctor, and there's many literature reviews about how that is so important for the patient. As a disabled person, where are my disabled doctors? How are we admitting learners to medical school? We have now a stream for black applicants and Indigenous applicants and low-income applicants. And the most important thing is not visible people that, I use a cane, not visible disabilities, that's only 3%. Is the invisible disabilities, the pain, the chronic illness, mental illness, HIV, substance use, which is very, very predominant in the medical and legal fields due to the stress and whatever you want to. So how are we going to mainstream the conversation of disability, which is also highly stigmatized, and to the point that people not only we will look at funny, but also they don't have a table that goes up and down so people can have a proper pap test. Or all of these different barriers and policies. When is the issue of inclusion of disability going to be part of EDI? Where's the A for accessibility?
Wow.
Yeah, that's a great question. Michel, I wonder if I turn it over to you first, given that your experience in respect of mental health and mental health challenges, and how I think that has some overlap with this question that we're being asked right now.
Yes, and of course I can't speak to precisely training for physicians. I'm not sufficiently versed in that. I'll let others speak. But certainly around inclusion and including that we are inclusive in there rather than exclusive is so important. So thank you for raising that. I've seen that in my own organization, because when we started off with reconciliation, and progressively after George Floyd incidents and others, we continued on that path, but also included EDI within our space. And it was, we started off with experts coming in, really assessing where we're at as individuals, as an organization, as a board of directors, and providing reports on our policies, et cetera, and what needed to change. But for change to really occur within our organization, we needed to tap our teams so that they would feel that they have ownership of this and can drive and really change our culture. And that's when EDI and inclusion became much more inclusive, and it included much more diversity. So it has had quite an impact on our culture within my own small organization. So it's a message that I take with me, and thank you for sharing that. I see, for instance, we participate in many international bodies. Why? Because we don't need to reinvent the wheel all the time. We can learn, and we call it brag and steal. So you can learn from your colleagues internationally and take what works well, so you steal it, and you adapt it to your own context. And one of those bodies, actually, we meet together with disabilities and mental health. And that really creates a very interesting forum for exchanges. So thank you for raising that issue.
James?
My best friend in medical school was Dr. Jessica Dunkley. She's the first female deaf physician in the country. She's also Métis, which is awesome. So having people included in the class that are diverse and representative of our society, like I always say, you taught us more than about disability just by being who you are and having your sign language interpreters at the front of the class than like any lecturer that came in and taught us about that. And we all had to learn and adapt to communicate with her innately. And even though she was let into our class, when she applied to, and she got accepted into dermatology at UBC, UBC would not pay for her sign language interpreters. And they kicked her out of the program. And to have a license to practice medicine, you need a residency program. And so there's a long way to go. And then she transferred to the U of A, and then Alberta Health Services did the exact same thing to her. So she launched a human rights complaint and won at the expense of 5 to 7 years of her training. And she's still finishing. She should have been done 9 years ago now. So there's a long way to go in medicine. But from my experience of having her in the class, she made us all better physicians. That, you know, not having her there, we would not be the doctors that we are today. So we definitely need more people from all backgrounds, including people with disabilities.
Yeah, and I think that gets to the point around education and the experiential component of it. How do we actually really learn? And it is through, right, actually being with each other and having the experiences with each other. So I was getting a signal. We did have one more question here. So if I may, right, and I just got the thumbs up. So there was a question just over here, I think. Is that right? Do you have the microphone?
Yes. Go ahead.
Oh, sorry. We have a question here and a question here. So you'll have to, you know, I'm going to have to beg forgiveness. Please.
Dr. de Villa, my name's Betty
Oh,
Lawrence.
Betty.
I'm one of
How
your
are you?
staff.
Yes, I can see you now. I see you. I'm like, that's Betty Wu.
Betty Wu Lawrence.
Yeah, how are you?
I am so grateful to be able to become a nurse in Toronto Public Health. In fact, I've been a nurse in Toronto Public Health for 37 years.
Woo, 37 years.
Thank you. I learned so much. I was a nurse from Hong Kong, and then I come here. Of course, they don't recognize my credential. I went to university and start all over again. But I know that I have so much more to learn at university. Political science. What else did I learn? Well, microbiology, and some of those things. Also, Asian study. Can you believe it? But anyway, I want to ask the question. I hear from our presenter you talk about the Asians contributing to the Canadian Railway. You talk about the resiliency, the difficulty of getting recognized in women's health and women's hand. I remember women's health and women's hand started by a couple of black women have to occupy the clinic in order to get it running. And Michel, Dr. Michel, Cambridge is such an important place for my ex who suffered from bipolar for 31 years. Without you guys, Dr. Thornton, he actually, when I asked for help, on the phone, we talked for 45 minutes. Even I didn't go to the emergency, I just heard about it. But anyway, my question is, when there is a crisis, when the COVID comes, all of a sudden, all the equity, all the inclusiveness gone out the window when the Chinese are being blamed and being attacked. And even though they contribute in the Canadian Railroad, but of course in the US it's a lot worse. Let's look at also one thing about that movie, Oppenheimer. And of course, he was talking about what this weapon is going to do. But what has ever people thought that the atomic bomb landed in Hiroshima because these are Asians. Asians are considered as subhuman. In fact, when they build a railroad in Canada, it's recognized in official writing. These are subhumans. They don't deserve any doctors. Even they work there. But anyway, we learn from it. And so much so, I'm being accepted for 37 years in Toronto Public Health to raise my family with that salary. Anyway, my question is, how do we convince the public what you are suggesting about more or less treatment for affirmative action? And our presenter talked about the need for accepting diversity, and also Cambridge talk about exploring new treatments and for things that we thought that mental health would never be cured. And my question is, what is it for them? The people's going to ask, the public is going to ask. You're talking about all these suggestions for better things. What is it for us, for the general public, let's put it that way, to listen to you guys? But I'm not going to give you a difficult question to answer. But I do ask my 5-year-old granddaughter, who's actually, this only happened in Toronto. I married an Irish and Acadian white Canadian, and my children is part Chinese, part French and Acadian, and my daughter married a guy from Trinidad. So my 4-year-old granddaughter asked her, what do you want to do? What do you want to do? What do you like the most? She said she wanted to be a bird. Now, I hinted to you, the things we are going to look forward to, the vision, to convince the public, may not be measurable, my dear Michel. So, but anyway, I'm saying, I want to learn from my granddaughter. What does it mean by being a bird? But anyway, my question is, how do we convince the public? What is it for them to listen to you? Thank you.
So thank you. And never let it be said that Toronto Public Health staff don't come up with great questions, especially Betty Wu Lawrence, right? I have been the recipient of many great questions, provocative questions from Betty Wu Lawrence. Colleagues, who would like to tackle Betty's question first? See? That's how I feel when I get a question from Betty Wu Lawrence.
So maybe I'll start by saying thank you for sharing your story. 37 years is quite a contribution, so thank you for that. Yeah. It's something I wonder daily, why people will listen to me. So I'll say that up front. But I think for our context, you need to demonstrate how much better we are together and how much richer our workplace, our lives are with us together. And let's put aside those who will choose to highlight individuals and blame them. I think it's an easy out, it's unfair, it's despicable. So from us, I think let's continue to share how much better we are together, and hopefully that will lead people to actually listen to us. I don't know.
That was good. That was good.
No.
That's why I played the music, Betty. Because I wanted to get people's attention. Why should people listen to us? Toronto Public Health is serving the city of Toronto. The city of Toronto is 53% racialized. Right, so for us to be having conversations about why should this community or that racialized community be supported, we make up the majority. I even have my students, they still use language like visible minority. And I'm like, we're not a minority in this city.
Yeah.
We are the majority. So if we don't start listening to diverse voices, if we don't start making changes within our systems to make sure that those folks that are racialized are not receiving services equitably, then we have a problem. We have a big problem that only half of the city is actually being served, and the other folks have to fend for themselves. And I don't know if people don't understand the fact, and I don't know why we struggle with this, right? The more diverse a workplace is, the more diverse a company is, the more successful it is. And the same has to hold true for our city, right? The more that we can actually embrace diversity, the more successful we all will be in the city of Toronto. So I think we have to really take a look at who lives here now. It has changed dramatically. It is going to change. We depend on immigration. Our city is going to become more and more diverse. So we have to adapt to the changing population. Now, the exception to that always is that Indigenous people, regardless of their percentage in society, have to be elevated to the top of our I don't want to say the top of the top level of how we engage, but we're in their country. So I take Indigenous people out of what I just told you in terms of we have to make sure that their interests are served first, and then we can look at the remaining diversity of the city.
James, last word?
I just keep on thinking about turning into a bird and what that's like. I think that's cool. What a good question she had. It's such an important question, and it really speaks to so many things, like the concept of meritocracy, which is false. But I think about this study that was done by the College of Physicians and Surgeons of Saskatchewan at the height of Joyce Echaquan's death, who was my age when she was killed by the health system. And we were talking about anti-Indigenous racism, which there's so many examples of in this country, Brian Sinclair, any number of things that have happened to my family. And what they studied was all of the regulatory colleges across the country. And they looked and saw how many cases have actually been identified as anti-Indigenous racism out of all the complaints against physicians. knowing that there's so many, knowing that like there was forced sterilization of Indigenous women, knowing that there was experimental studies on nutrition on Indigenous children in residential schools, knowing that the BCG vaccine was developed on Indigenous children in residential schools, or the Canada Food Guide, like any number of things, and there was zero cases of reported anti-Indigenous racism. And when we look at the bodies who investigate that, there's no people of color, there's no Indigenous people. So if we don't know what the experience of racism is ourselves, how are we going to look at nuanced experiences of the look that you get when you go into the emergency room, or the tone of someone's voice, and how that impacts the care that you receive or don't receive? And so that's the value of having diverse representation, is we can collectively look at something with all of our different colors of glasses, or all of those things, and come up with a solution that helps address the issue that we're trying to look at and discover. And so I will learn so much from you and like everyone else because of the experiences that you bring, and together I think it provides a richer solution and to many of the issues that we face.
Well, thank you. And I am now officially getting the signal. I'm sorry, I know there was one more question out there. Perhaps we can get to that, after the fact. But I think we're at that point in the evening where I'm left to wrap things up and say thank you, thank you, thank you for your time, for your insights, for your wisdom, for sharing your experiences so openly with all of us. Michel, Notisha, James, thank you so much. And if I can, people, a round of applause for this amazing group of professionals. I can certainly go on for hours. I will try to keep this short because I realize we're close to time. I do have to say thank you. It took an entire team of people at Toronto Public Health to bring this event to fruition. If you will, a round of applause for those who actually made this evening a possibility. There are too many to name. I would name them for you, but there are too many to name. And last, but certainly not least, my thanks to all of you for being here this evening, for taking the time, for asking fantastic questions. I do hope there's a little bit of opportunity for you to interact with each other, to continue the conversation, and I hope to see you again at another one of these events at some point in the not too distant future. Thank you very much, everyone. Have a wonderful, wonderful evening. And thank you.